Welcome to Chapter 2, Processing. In this chapter, we're going to be talking about the processing schedule, some of the individual parts of processing, and how we process certain special tissues, such as bone and anything used for frozen sections. During the dehydration step, which comes right after formalin in our laboratory, what's going to happen there is we're going to use our alcohols. So we have graded alcohols. They start out at a fairly low concentration and they work their way up. And the reason we do this is both to expose the tissue to the alcohols, which is kind of part of fixation, but it's also to remove any excess water. We just want to remove anything that's going to be in the tissue that will interact with our infiltrating agent, which is paraffin in our laboratory, because that medium will not infiltrate something that has water, because it is not miscible. And we're going to hear that a lot. When something is miscible, it means that it readily mixes. So when you have things that don't mix, they just kind of push each other around, and then you don't really have a complete infiltration. Let's talk about some of our dehydrating agents. We'll start with just general alcohols. In general, when you have an alcohol, you want to keep the concentration relatively high. As some authors have suggested that anything less than 98% concentration is too low. Okay? And it may leave excess water in the tissue, and then when that tissue hits the xylene, it'll turn kind of cloudy and you get a weird precipitate in there. As some folks may use as low as 75%, but then they will grade those alcohols up from there, eventually reaching absolute. So that's the important thing. You can use some lower concentration alcohols or dehydrant in the processor, but you do have to grade them up the whole way until you get to something that is at least 98% alcohol. Now with alcohol, we have the ability to add some things to make biopsies a little bit more visible. So if you can add eosin or some other colorant to it, then that biopsy will show up. It will absorb the eosin and you'll be able to see it when you go to embedding, whereas if you didn't, they tend to be a bit more translucent and they're a little bit harder to find. Within the alcohols, there's obviously a variety of reagents that we can look at. So let's start with ethyl alcohol. Ethyl alcohol can be used in most processing schedules. It's very versatile and fast acting. Many laboratories will start with a concentration that's pretty low, so maybe 65–70%. And you may ask, well, why do that? If you can start at a higher concentration, wouldn't it be faster? And the answer is yes. The overall time would probably be faster. The dehydration process would be quicker, though the drawback with that is that the shrinkage that comes with ethyl alcohol as a fixative is a bit more pronounced when you start at a very high concentration. Also, if you're using phosphate buffered formalin, any concentration above 70% is going to cause a precipitate from that phosphate buffer to fall out, which will get into your tissue. So if you're using ethyl alcohol and phosphate buffered formalin, it's important to start with anything less than 70% ethyl alcohol. And also you want to mitigate that shrinkage factor. So that's why you're going to see those graded alcohols on a normal processing schedule. Methanol is another alcohol. It's not typically used in tissue processing. A lot of times you'll see it used for smears because it's very fast acting. The reason that we don't use it in routine tissue processing, among some other things, mostly is because its toxicity is relatively high. The PEL of methanol is 200 ppm. So that's 200 ppm over 15 minutes is considered to be too dangerous by OSHA. Whereas ethanol is around 1000 ppm, so it's a lot safer to use ethanol if you can. Next form of alcohol is isopropanol. Isopropanol works fairly well to process tissue, but it has a few drawbacks. It does not allow for eosin to be used in the processor. You can't use it in a stainer as well because it won't allow for eosin to be absorbed. Also, you can't use any nitrocellulose as your infiltrator. if there's isopropyl alcohol present. And there is a bit of water that's also left over with isopropanol. And lastly, I personally have heard stories of how isopropanol tends to smell. Now that doesn't mean that's all bad. While there are some drawbacks, isopropanol is also not regulated by the government, which means it's easy to maintain. Our next alcohol is butanol. The problems with butanol are that it has a pronounced smell, it's slow to act, but there is one advantage that it tends to have less shrinkage than ethanol. So if you were to, say, processing something with only an alcohol and you used butanol, you might have a little bit more luck if you weren't using formalin, let's say, in a research setting. Lastly, while acetone is not technically an alcohol, it acts very similarly in the processor. The difference is that it evaporates very quickly, it's very easily flammable, and it tends to cause a little bit more shrinkage than the alcohols do. Our next kind of reagent is called a universal solvent. Now, so far in your processor, your tissue have been through fixation, so they've been in your formalin, then they've gone through dehydration, and typically they would be going on to clearing next, and then infiltration with your medium. So universal solvent takes the second and third step there, the dehydration and the clearing, and just does them both at the same time. And this can save a lot of time. Obviously, you're skipping an entire step in your processing schedule. 3 common universal solvents are dioxane, tertiary butanol, and tetrahydrofuran. All 3 of these tend to have some health risks, as are many of our reagents. But really, the big drawback with this is the fact that your tissue is having those 2 steps done at the same time. Unfortunately, a lot of our tissue is very delicate. And so when you're moving all of the water out of the tissue, and then moving solvents around in it during the clearing step, and you're doing those all at the same time, you're moving fluids in and out of your tissue at a very rapid pace, rather than spacing it out between 2 steps. And when you do that, it can kind of distort the tissue. You can sort of move things when, remember, fixation, our whole point was to keep things in one spot and to preserve them. So a universal solvent can kind of distort things in a way that we really don't want them to be. That being said, what is clearing? Well, clearing is when we kind of push our dehydrating agent, so whether that's an alcohol or acetone, we're going to push that out of the tissue. Okay, if that reagent is done doing its thing, it has dehydrated the tissue exactly as much as we wanted it to be, so we're going to kind of push it out with something it's miscible with by adding a big concentration of it. So we're just going to push something through, going to stop the dehydration process. Also, by having this clearing agent in the tissue, it makes infiltration happen a lot easier. So clearing is kind of an in-between step. It facilitates stopping the dehydration, and then it also facilitates starting the infiltration step. So you might wonder, well, it seems like it's kind of an extra step, right? You don't necessarily have to facilitate something to make it happen. So why not just skip clearing and just go from dehydration to infiltration? So what would happen there is, obviously, dehydration would continue. So you would have things that would be overly hardened. You would have an infiltrator that's trying to go into a tissue with something that's not miscible with. So it would be trying to kind of fight with a dehydrant, so say an alcohol. So you'd be trying to get your infiltrator, typically paraffin, to kind of push the alcohol out. And it's not very effective. You're going to get a lot of incomplete infiltration, and that's not something you want. Let's take a look at some of our clearing agents. The first one is xylene. So everybody's heard of xylene. Our laboratory uses it, and xylene does just as you would expect. It goes into the tissue and pushes out your dehydrant, in our case ethanol. It pushes that out, and then it allows for the paraffin, our infiltrator, to work its way in because it is miscible with paraffin. And so xylene is kind of the kind of the benchmark for other clearing agents. Next is toluene. And toluene is an interesting one because toluene is very similar to xylene. It acts in a very similar way, except you get less hardening, so it seems like it'd be really great to use. And it is. It's another one of those things, a lot like some of our fixatives, where they're ideal as long as you're paying attention to the factors in your laboratory, and as long as you're able to control those factors. With toluene, that factor is humidity. So if toluene gets too much water around it, or if the laboratory is just humid, maybe your atmospheric controls are not great, in which case you'll get incomplete H&E staining because toluene does not clear well if there's a lot of water in it. So in that case, toluene is a bit more volatile in its performance, but you can also leave it in a specimen in toluene overnight without it hardening. So that's something to consider. Another reagent is benzene. And a lot of us have probably heard of benzene. It's particularly dangerous. It's a very potent carcinogen, especially in the blood and bone marrow. It has a very low tolerance for benzene, setting the tolerance right around 10 ppm. And so you get a little bit of exposure to benzene is considered to be highly, highly dangerous. Now, benzene could be good if you're in a very well-controlled lab. It doesn't harden tissue as much as xylene unless you're working with tendons or uterus or muscle. So if you're working with a lot of that, then benzene's not your thing. It's going to harden those tissues. But anything other than that, maybe a derm lab might use benzene well. There's another problem with benzene, being that it evaporates fairly quickly. So if you're using an open processor, then it can evaporate and it can be hard to keep the levels clear. On the other hand, it tends to not stick around in your paraffin. So, when you go to change the paraffin in a processor, it tends to have that xylene smell or whatever clearing agent you're using. The benzene tends to not stick around in there, it tends to evaporate. So you can keep using the same paraffin in your baths longer without changing them. Another reagent is chloroform. And chloroform has a lot wrong with it. So let's just start with the benefits. The benefits of chloroform is that it leaves tissue a little bit less brittle than xylene. And that's about it. Okay? It evaporates extremely quickly. It's heated, it becomes super toxic. It makes phosgene gas, which does terrible things to you. I think maybe we might have used phosgene gas in World War I. So you don't want that in your laboratory. Carcinogen. So I would say avoid chloroform if at all possible. Our next reagent is kind of an interesting one. It's acetone, which is weird because we used it as a dehydrator last time, right? So in this case, it's not really a clearing agent so much as it's a dehydrator that we left in the tissue. The difference with acetone is that evaporation, that rapid evaporation that comes with acetone, allows it to kind of clear itself. So when the paraffin goes to infiltrate, or wherever your infiltrator is, goes to infiltrate the tissue, it's not fighting with anything. There's nothing there, it's evaporated. So it just infiltrates the tissue just by itself. Doesn't really need a clearing agent to get rid of anything. So it tends to work fairly well in a well-controlled environment. It's just not used very often because of the other disadvantages that come with acetone, mainly the excessive shrinking. Next class of clearing agent is essential oils. Seems like a weird place to put essential oils. They're very expensive. The aroma of a concentrated essential oil at the concentrations we would need to make them effective tends to make them kind of nauseating, really. There's too much smell going on there, and they have to be cleared out of the tissue completely. Xylene, which sort of defeats the purpose, right? So if you're going to use a clearing agent, you might as well just use xylene. Why use a essential oil first? The answer is people use them during research. They tend to not harm the tissue as much, especially cedarwood oil. This is one to keep in mind. Cedarwood oil is extremely, very, very gentle with tissue. In fact, write this one down. Cedarwood oil is a clearing agent that you can leave tissue in almost indefinitely. It won't hurt it. So it's even better than toluene, which you can leave tissue in overnight. Cedarwood oil, you can just leave tissue in it indefinitely. So that's the one big advantage there. Our next clearing reagent is the class of limonenes. And limonenes have been used right around the time when they were first kind of discovered in the histology context. They were used as a xylene substitute because they weren't technically hazardous as xylene was, though we're not entirely sure how damaging xylene is. But we kind of knew that limonene wasn't as bad. The problem with limonene is that the smell can be a lot for some folks. It can be a sensitizer, which is not great, meaning that prolonged exposure to limonene can actually cause allergic reactions to show up when you didn't have any. And also, I've heard stories of limonene causing kind of a scum to form around your processor and around the lab. So it tends to kind of aerosolize and get all over everything. Limonene is essentially like lemon oil or citrus oil. So if you're really needing a xylene substitute, it's something to consider, but just keep in mind that the sensitization problem can be a thing. Also, that residue can sort of be a problem as well. Finally, our last class of clearing reagent is aliphatic hydrocarbons. And these are sort of the newer class. They tend to be used as xylene substitutes. They act very similarly to xylene, but they're a little bit more finicky. So it's one of those things that's great as long as you have a lot of control within your laboratory conditions. Humidity can really mess with them, but if you're able to keep that up, then you have a valid xylene substitute, which is great for the health of your fellow techs. Now we're on to our last step of processing, which is infiltration. So everything up to this point, the dehydration, the clearing, has been done in preparation of infiltration. While granted, our alcohols might help with fixation, within processing, they're mostly there to get rid of the water. Okay, if there's water in there, then your infiltrator can't get in. So we get rid of the water. Well, now you have your dehydrator in there, which many times is not miscible with your infiltrator, so we'll throw a clearing reagent in there to get rid of that. So at this point, your tissue has your clearing reagent in it, typically xylene, and and so now you throw your infiltrator in there, and it replaces the clearing reagent. So once your infiltrator is in, it kind of supports the tissue. After embedding, it hardens, it fills in all the gaps. And so it keeps all of the tissue pieces right where they're supposed to be. So without an infiltrator, you would go to cut, and the pieces might move with the blade, they might get compressed, and you might have pieces fall off. So this just kind of keeps that piece of tissue that we've been trying to keep, whose structure we've been trying to preserve this whole time, is now kept in a physical plane the entire time during microtomy. Of course, if we're going to talk about infiltrators, our first one's going to be paraffin. And it's widely used, it's very inert. It's a petroleum product that tends to have other things added to it, things like beeswax and rubber, and all these things just help the block to cut better and to form smaller crystals, which we'll get to. But essentially, paraffin's kind of the standby. You can make a lot of blocks with it in a short amount of time. And also, one of the factors that we kind of take for granted at microtomy is that with paraffin, when you take a section, the first section comes out across the blade, and when you take your next section, the second section adheres to the first one and pushes the first one out. And that doesn't happen with other media, typically. So if you do a frozen, obviously you don't get a ribbon. So ribbon is typically a paraffin thing. One factor to keep in mind when we're selecting what sort of paraffin to use in certain contexts is the melting point. So as the melting point of your paraffin gets lower, meaning that it's a little bit less solid at room temperature as the melting point goes down, the softer it's going to be. As the melting point goes down, you tend to get softer blocks, which means they're going to have a little bit less support, which is very important when you're talking about things like bone. Things that are very, very hard need a very hard wax, so that when the blade hits it, the bone flexes as much as the paraffin does. So if the paraffin flexes more than the bone, then the bone tends to chunk out. And we don't like that. That stinks. We have to re-embed it. Though, as that melting point goes down, we also get better sectioning. So if we're taking something like a biopsy and we need to get 12, 10, 6, whatever sections at a time, and we don't want to keep going back into it, having a softer paraffin is really helpful. So in a lab that handles a lot of different types of specimens, you kind of have to look at that. You have to notice what your ratio is and see how much you're willing to give on either one of those things. Is it worth getting really great sectioning if it means that sometimes your bone, maybe cervix conizations tend to pop out? Or is it better to have a harder paraffin that's maybe a little bit harder also to get sections from? With paraffin comes some factors to keep in mind. Other than the melting point, you have to talk about how long it's in the hot paraffin in the processor and in embedding. In the past, we've said that perhaps having the tissue in hot paraffin for too long causes overhardening. And it does, but more recent studies have found that while that does cause it, that only happens if incomplete dehydration and clearing happen first. So if your dehydration and clearing are proper, then you're not going to have that hardening problem. Many processors use a vacuum to help with infiltration of paraffin. And what that does is it's pulling out all the air out of the tissue. And when that air is taken out, it pulls the paraffin with it. So it's kind of like pulling the paraffin through a sieve. So as the air leaves, paraffin infiltrates those spaces that the air was before. And the more paraffin that you get into your tissue, the better it's supported. We've gone over routine processing that happens in most labs. Let's talk about processing schedules just a little bit. Typically in a processing schedule, you have your fixative first, so typically formalin. You're going to have just one of those, and then you're going to go into your alcohols. So if you have phosphate buffered formalin, it's important to have probably more than one step of alcohol, so you're going to have that at least 70 or below step, and you're going to want to grade it up to absolute so that you get rid of all the water. So it's really hard to do just a single alcohol step when you're using phosphate buffered formalin. So at that point, everything is dehydrated. So you're going to go on to your clearing step, which is going to be typically xylene. A lot of folks will use multiple steps for this too. If for no other reason, it means that you're going to be using more reagents and you kind of stagger them. So you might have one that's going to need to be changed today, one will be needed to change the next day. That way you're not changing your xylene every day, and you're also not changing a huge volume of it all at once. And then after that, you move on to your infiltrator, which is typically paraffin. During an infiltration step, you might have multiple steps. What this allows for is kind of the same thing with the xylene. You want to have multiple baths that can be changed on a staggered schedule. Also, it allows the tissue to have a few exposures. Just having that velocity of new, highly concentrated infiltrator in there can kind of help fill in all of the spaces. When choosing a processing schedule, typically you're going to look at what kind of tissue is in the processor. So the schedule is going to change depending on if it's large tissue, so colons, or if it's fatty, so if you might have a breast tissue, or if you have biopsies. Typically biopsies have a shorter schedule, and large and fatty tissues tend to have longer schedules, just overall. Also, those schedules are going to depend on how many cassettes are in there in total. So if you're going to process a couple of cassettes, you can use a very, very short schedule with a lot less reagent. Or if you're going to do a few hundred, then you're going to need a much longer schedule. Reason being that all of those reagents have to hit all of those specimens entirely. You want them to be completely done in each one of those steps. So if you do 100 cassettes on a 5 cassette schedule, then a lot of the cassettes are only going to get hit on the outside. A lot of that tissue is going to be dehydrated and cleared and infiltrated on the outside, and they're going to be raw in the middle. So we've selected our processing schedule, but how do we know if it worked? And the way we do that is through validation. So what we'll do is we'll take tissue of the same size, thickness, and fixation time, and just put them, a few of them, in the processor and run them all at the same time, and embed them the same way, cut them the same time, same at the same time, and then see if it's consistent across all of them. That way, you know that if your processing is not just some sort of fluke, you want to make sure that it is a repeatable thing, so you can run them multiple times. They're always going to be the same. One processing type that I personally haven't seen but I've read about is microwave processing. Now with microwave processing, as far as I know, there aren't any automated processes in place. This is more for small batches. So in this case, you would take your tissue in the cassettes and you put it into a container in a microwave. And you use a laboratory grade microwave, obviously. And you kind of change out the reagents yourself. So instead of waiting for your processor to move things in and out and doing all the vacuum infiltration, all these things, you just do it manually. And this works pretty well for small biopsies that don't have a lot of tissue to push things through. So the surface area to volume ratio is really good. So in that case, you don't have to worry about incomplete fixation in the middle of them so much. Just kind of sitting in the reagents in a microwave is enough to process a lot of biopsies. Now, we've talked a lot about paraffin infiltration, but there are other ways to infiltrate, and they don't require dehydration and clearing, which is kind of nice. And that's with the use of water-soluble waxes, collectively known as carbowax. And when using those in processing, you would just use a water-soluble fixative, so like formalin, first. So you fix your tissue, and then you would put the tissue into the carbowax, and you just kind of let it sit in there until it falls to the bottom, which means that it is now dense enough that it is filled with the carbowax. And then at that point, you just embed it, and it's ready to go. The reason folks might do that is because obviously there's a lot less processing going on, a lot less steps, which can be nice. Some folks think that it cuts a little bit better. There are some drawbacks though, because the water solubility tends to get in the way. So because it's water soluble, your blocks can break down if they get wet, which is bad. So typically we put our blocks on ice water. You can't do that. If you want to chill your blocks, and they do cut better chilled with carbowax, just like paraffin, then you need to put them in a refrigerator, and it needs to be dry. Some folks have said that it does cut easier, and that's great, except you also have a floating problem. Kind of when you put a paraffin section on water that is too hot, the sections from carbowax can kind of blow apart in a similar way. Another alternative infiltrator is called colloidin. It's a form of nitrocellulose. And why you would use colloidin is typically restricted to sections that are coming out of the central nervous system. So if a pathologist works exclusively with pieces of the central nervous system, maybe in a research setting, you might use colloidin. A lot of problems come with colloidin, though. The blocks need to be treated with a lot of alcohols, and the blocks need to be kept in a high concentration of alcohol in order for them to not dissolve. Also, the blocks need to be desiccated with chloroform, which is a problem. But pathologists have said that it is without equal when trying to get sections on a central nervous system. That there's no heat and there's no shrinkage, so it actually preserves things incredibly well. Next infiltrator is glycol methyl acrylate. It's a type of plastic. So plastic embedding in general, what you get is a very, very hard block. And very, very hard blocks, as we know with paraffin, when you have something that has a very high melting point, provides a lot of support. So if you want to cut things like bone or anything that needs a lot of support like that, then this can be really great. And specifically with plastics, you can cut things that are very hard at a very, very thin section. So 1 to 2 microns you can cut plastic at. Now, when you're cutting plastic, you don't use a steel knife like we do with paraffin. We use a glass knife or a Ralph knife. And that's just because of the way that plastic is. There's different crystalline structures in paraffin, and plastic is a little bit different in its makeup, so glass knives tend to work better. Now, the problem with plastic is that compared to paraffin, it doesn't really melt that well around room temperature, and so you can't really remove it that well with chemicals either, and it doesn't really adhere to slides all that well, and it's also kind of hard to remove from the tissue, which we usually do when we stain paraffin embedded sections. But that does leave a good bit of the enzyme activity to be active. So if you're doing enzyme reactivity studies on something that is very hard, then glycol methylcrylate might be a choice for you. So our next alternative medium is epoxy. And what epoxy is typically used for are things that need to be very, very thin. So things like electron microscopy, things where you need to see ultrastructures. So when you need to see like the mitochondria or Golgi apparatus or the ER specifically, you need to use epoxy. And it's just the way that it sections, and it's just the way that it doesn't get in the way of the procedure behind electron microscopy is why you would use that. Also, you can cut it extremely thin. So when you're cutting epoxy resin, you use a diamond knife for the thin sections, and those can be cut anywhere between 60 to 90 nanometers. Now remember, we cut in microns for paraffin, so we're down to nanometers here, very, very thin. Though when you go to look at something under a light microscope that's been done in epoxy, you use a glass blade like you do with some of our other plastics like glycol methylcrylate, and you cut that at like a 0.5 micron and just put it under the light microscope. Our last embedding medium and infiltrator are kind of grouped together as agar and gelatin, and they act similarly. What you would use these for is if you have a lot of friable tissue or a lot of tiny pieces that you want to put into one block and kind of hold in place well. You use agar and gelatin first, and sometimes you might embed it a second time. So you'll do a double embedding where you kind of embed it in the first one and then embed that in paraffin to give that the outlying support. And like I said, this is mostly just used for little tiny fragments or friable tissue. The agar and the gelatin just hold it really well during microtomy. You've done your processing, but you're running into some problems, and that happens, especially if it's a new processing schedule or you're changing reagents, trying to find the best fit for your laboratory. Some things you might run into are precipitates. So you've done your run and you find some strange precipitate in one of your wells or in the chamber itself. Typically, if it's phosphate buffer formalin you're using, then maybe your alcohol was too strong. One has to be kept at less than 7, so it has to be at least acidic in order for the zinc to not precipitate out. Maybe everything looks great on your end, so you've embedded everything, it's cut, sent off to the pathologist, and they say, hey, these GI specimens just look terrible. These biopsies just have so much chatter in them. What's going on? You say, well, we've been soaking them, we've done everything in microtomy, and you think, maybe it's processing. It could be. Maybe they've been dehydrated for too long. The way that you prevent that is, for one, make sure biopsies are on their own schedule. Don't put them in with other things, because they dehydrate a lot quicker than your large pieces. And maybe change your dehydration schedule, specifically for biopsies. Perhaps your pathologist has said that they're getting poor staining. Maybe there's no nuclear staining on this whole run. So say, what's going on? Typically, you're looking at your reagents. So maybe it's just lack of maintenance on the processor. Perhaps your alcohols aren't strong enough. Things like that. So you just kind of have to check your temperatures, check your concentrations of all your reagents to make sure everything is as it was when you validated that process. One artifact that the pathologist might come across is a sponge artifact. So a lot of times when we have small pieces or maybe skin shaves, the path assistants will put them between two pieces of sponge, which is great because it holds it in place, we don't lose it, it keeps the orientation. But if those sponges are dry, if they're not pre-soaked in a fixative, they're going to take that that kind of spongy texture and transfer it to the tissue. So all of a sudden your tissue kind of has a spongy texture to it, and when it goes to stain, it has incomplete staining. It just kind of cuts into it, and you see little triangles all throughout the tissue, and that's called a sponge artifact, which is something you don't want. This problem doesn't really happen in most laboratories because it's kind of more of an open processor problem, and those are fairly rare. Though, if for some reason, if the tissue has been accidentally desiccated, meaning that it's been left out of any kind of reagent for a long amount of time, and it has somehow made it into embedding, and you find out that it's been left out, then you want to just rehydrate it. Use a rehydrating agent. Depending on what your infiltrator is and all the other steps, that rehydrator is going to change. But yeah, you just have to rehydrate the tissue, and it's not going to be great. Desiccation does do a lot of damage to tissue, but it might recover it to the point of being able to get that diagnosis back. So now that the processing has been done and you're kind of ready to embed your tissue, let's talk about some tips for embedding. Typically, if you're watching this video, you've already done some embedding, but hey, maybe not. So let's just talk about the basics of that. When you get your cassette, the path assistant has already cut the specimen, put it through the processor, and they've put the specimen in the cassette the way that they want it to be embedded. Typically, especially if it's a large piece, it's common practice to take it out of the cassette and put it immediately into your embedding mold in the same way that it was in the cassette. So the face that was down in the cassette is the face that's down in your embedding mold. Now once it's in there, you have your paraffin in there as well. Some people fill before, some people fill after. I fill before, but performance changes depending on the person embedding. So now you have your paraffin in there, you have your specimen in there. You want to make sure that it is held down, and then you go and bring it to the cooling plate. And you make sure that all the surfaces that need to be down are down in the same plane. You want it to be flat, but you need it to be flat in the way that the specimen, that specific specimen, needs to be flat. So if it's a big piece, let's say breast, that just means the whole thing needs to be flat down the way that it was in the cassette. If it's a skin, on the other hand, then you need it to be flat on its cut surface. The cut surface has to be down so that you can see your epidermis, dermis, and everything else. So that piece right there has to be flat. If it's something with a wall, it's kind of the same thing. If you have a colon, you need to be able to see the lumen, and all the other layers have to be able to be displayed in the same plane. So all those have to be flat against the embedding mold. Now if we're talking about something with a tube, kind of the same deal. You want to be able to see everything all at once. So if it's a tube, you want to put that piece down. Recommended that something like bone, something very, very hard, is put on diagonal. Essentially so that your blade doesn't hit one big hard piece all at once. And so when your blade on the microtome hits the paraffin, it kind of has the same hard to soft ratio, which we'll kind of get into in microtomy, but you want changes in microtomy to be gradual rather than abrupt. So you don't want the blade, when somebody goes to cut the thing you're embedding, you don't want them to go from soft to really hard all at once, because that causes a lot of vibration in the blade, and that eventually causes things to chunk out or just not section well. Sometimes when you're embedding, you run into your problems that were actually part of processing. So you might get a piece that seems really, really soft and maybe was underfixed, in which case you just want to reverse the processing. A process that is part of processing but doesn't really occur in a processor per se is decalcification. So when you have tissue that is too hard to cut, in this case in paraffin embedding, if there's any calcifications, they're not going to cut well. So you need to decalcify them before they get into the processor. typically the tissue is either completely unfixed or completely fixed at this point. So you could decalcify it beforehand and then fix it, or fix the tissue and then put it through your decalcification method. Now there are two main types of decalcification. There's acid methods and there's chelation. First we're going to go over acid. So acid methods can differ. Sometimes it's just kind of putting things in acid, sometimes there's some electrical components, sometimes there's some ions. So let's start with simple acid decalcification. Actually, simple acid decalcification is just putting your piece of whatever, typically bone, into an acid and monitoring it. So you make sure that your acid is taking out calcium, so you might use something like nitric acid. It works really well, it's very fast, and what that's doing is it's just exchanging ions constantly. So the whole point of decalcification is to remove calcium. So putting something in an acid just takes calcium out and binds it to that acid. So how you monitor this, typically somebody might take something out and do a bend test, where if you can bend the bone a certain amount, then it's ready to go. If it doesn't bend at all, it needs more decal. If it bends too much, you might have over decaled it and made it kind of fragile. So a lot of times you need to check that endpoint by some sort of physical means. The second acid method is an ion exchange method. This one is probably one of the best. So in this case, you're using an ammoniated salt of a sulfonated resin, and you're adding formic acid to that and then putting your specimen in there. And the way that this reaction works is it essentially keeps the calcium at a certain level in the actual medium, and because of this, there's no sharp endpoint here. You can kind of leave it in there, and when it's done, it's done. It doesn't keep going. You're not going to completely dissolve your specimen in an ion exchange environment, and it's also said to be pretty good with staining. So if you had to choose out of any of the things in an acid decalcification method, ion exchange is probably your best bet. So our third acid-mediated method for decalcification is just electrolytic. So what we're going to do here is actually attach our bone to an anode, which is a positive pole, and we're going to have a cathode in the outer part of the solution. We're going to run electricity through that, and what that does is it causes electrons to flow. So in a lot of electron physics, opposites attract. So calcium is a positive ion and is attracted to the cathode, which is negative. So your bone is on the positive, the calcium is going to the negative. So what you're left with is a piece of bone sitting on your anode that doesn't have any calcium in it, because it's all hanging out on the cathode. Now, the electrolytic method is incredibly effective in that you're just ripping the calcium ions right off the bone, but because it is so rapid, it can actually cause burns on the specimen itself, because the ions are being pushed so quickly out of the specimen. So you have to watch that. If it runs too fast or too long, then you can actually get a burnt piece, which is not something you want. If we're not going to use an acid method, our other method is chelation. And chelation is essentially adding a chelating agent called EDTA, typically, is what you would use. And you just add your bone to the EDTA, and the EDTA binds only to calcium ions. So it's also very safe, it's also very slow. So I would put this just under your ion exchange method, where the ion exchange method is also very safe, but it's a little bit faster than chelation. The chelation is also very safe as well. So let's say we think that our decalcification is done. How do we know for sure? We've talked about the mechanical method, right, where we take it out and kind of bend it and see how bendy it is. That's not super accurate. It's fairly common, but it's not incredibly accurate. There are also chemical methods where we add some things to the bone and see how turbid it becomes. It's a lot like checking for the if there's water in your xylene, or if you have xylene in your alcohol. You're kind of looking to see how turbid that reaction becomes. The third way is radiographically. So you essentially take an X-ray of the specimen to see how translucent it is on the X-ray, and that'll tell you how much calcium is there. So far, we've talked about processing, we've talked about decalcification, but what if something needs to be cut right now? What if a patient is in surgery and they need some sort of diagnosis or maybe an adequacy for a specimen needs to be known right now before they finish surgery and send the patient home? Well, that's when a frozen section comes in. So when a frozen section call comes in, the surgeon will typically allow us to know that ahead of time. They'll mark a specimen as being frozen, and the specimen will come directly down to the lab. At that point, it is accessioned, and a proverbial clock starts ticking, because the patient is still in surgery, they're still opened up. Every second that that specimen is not completed is another second that person's in surgery. So once the specimen comes in, somebody will gross it. Sometimes it's the PA, sometimes it's a pathologist. They will gross it, and if your techs do frozen sections, then after what's gross goes to your tech. So whoever gets it next is going to take that piece and put it onto a chuck. Now, there's detachable chucks in frozen microtomes or cryostats. So you take that piece of the chuck and you just kind of put the tissue on it with a little bit of your embedding medium, which is a special embedding medium that turns solid when it's cold, and it's a little bit, it melts at room temperature. So you kind of squeeze it on there and you put it onto what's called a heat extractor, which is essentially something that's really cold, and that hardens it. So now you have a chuck with a piece of specimen attached that has a solid embedding medium around it. So it's a lot like cutting paraffin at that point. So you take that and you insert it into the rest of your chuck. So now you have a chuck with the other piece of it with the tissue embedded in your frozen piece. Now, when you're using a cryostat, everything is going to be cold, has to be kept cold, or else the embedding medium will melt. So the entire thing is kept cold. It's typically in a covered enclosure. And also the embedding medium is not paraffin, so you're not going to get the sectioning that you would normally get. Typically with frozen sectioning, you keep cranking until you get full face, just like with paraffin, and then you try to get a single section. So a lot of times when you're doing that, you kind of make contact with the blade, like normal, but then you'll kind of tease out the section with typically with some sort of brush. And you can kind of tease that section out, and once it's ready, it's completely a full section, and you grab a slide, typically a warm one, you might warm it with the back of your arm, something like that. You place it down, and it kind of picks up the section. Okay, then it's immediately adhered to the slide. So notice, there's no water bath here, because if you put something like that on a water bath, it's going to dissolve immediately. In fact, if you take it out of the cryostat, it's going to dissolve pretty fast. So you just put a warm slide on it, and bam, you already have your section. Something to keep in mind when you're cutting on a microtome or a cryostat is that this tissue hasn't been fixed yet. So it's raw tissue. Specifically, you think about tuberculosis is a big thing. If you hit the block with some sort of freeze spray, which you often might do to make it harder, that can aerosolize tuberculosis, which is really bad. You don't want that. You don't want to catch that. Something else to keep in mind is if something's very, very fatty, you might have to freeze it even more so than the cryostat is. So you might need to use liquid nitrogen to kind of super freeze that section in order to get a solid section off of something. And after you get the section, so it's on your slide, then you're going to take it through an abbreviated staining. So instead of putting it on a machine, typically you would do it by hand. Unless you're in somewhere where you're going to do multiples of these, in which case you might use a kind of dip and dunk sort of staining method where it does one slide at a time. But in either case, it's very fast, so you'll hit it with some formalin typically to preserve it, and you'll run it through a typical staining process. All in all, you can get a frozen section done in 10-15 minutes. in which case it goes directly to the doctor. They'll read the slide, make the diagnosis, and then that surgery will continue depending on what that diagnosis is. That's pretty much it for processing. So we've made it through a second chapter together, and here you are. You might think there's a lot going on here. There's a lot of different reagents that act differently in this book. Unfortunately, a lot of that's going to come down to memorization, but processing is something we can tackle in a hands-on approach. So if processing schedules seem kind of strange, go ahead and go to the Histotutor site. There's a processing simulator there where you can just click on the instructions. It'll tell you everything, how to go about it, but essentially you kind of set your own processing schedule, and then at the results on the bottom it'll tell you if your tissue is on the harder side or the softer side, and you kind of can play around with concentrations and times. Now granted, not everything is included in the simulation, so you can technically start with a 30% formalin. You're not typically going to have that, or you can start with a 10% alcohol after formalin, and it's not going to tell you you're going to have a precipitate, but it's more about how those concentrations and times affect the tissue. So go ahead, take a look at that. As always, feel free to give me any feedback about the video. If you have any questions, come find me, and have a great day.